Hello, and thank you for being here. My name is Ashley Richter, and I am a DNP candidate for Maryville University's BSN to DNP program in the Pediatric Nurse Practitioner concentration. Today, I will be presenting my Doctor of Nursing Practice scholarly project on the development of a clinical practice guideline for managing type 1 diabetes in schools titled Establishing Guidelines for School Nurse Management of Type 1 Diabetes. I'd like to take a moment and thank my project chairperson, Dr. Pauline Foy, and my community member, Connie Tan, for guiding me through this project. They both have been invaluable resources. I'd like to start by providing some background and what led to the significance of my project. Type 1 diabetes is a chronic autoimmune condition in which the body attacks insulin-producing beta cells in the pancreas, resulting in little to no insulin production, causing blood glucose levels to reach dangerously high numbers. There are over 100,000 schools in the United States who serve over 50 million children. Type 1 diabetes impacts about 1 in 300 children by age 18 and is one of the most common chronic conditions affecting school-aged children. As a result, type 1 diabetes requires continuous monitoring and management. Children spend on average 7 hours a day at school, making the school nurse an essential role in maintaining and coordinating student safety. Unfortunately, budget constraints within school systems have forced institutions to reduce on-campus nurse availability, and in some cases have even been forced to eliminate the position completely. Such decreased availability on campus has forced nurses to delegate care to unlicensed assistive personnel. In my role as a school nurse, I observed that many of the schools rely heavily on the individual nurse's knowledge of disease processes, plan of care development, and their ability to educate unlicensed assistive personnel, who often have varying levels of experience and clinical understanding. This variability in both nurse expertise and unlicensed assistive personnel training contributes to inconsistencies in care delivery. Standardized, evidence-based protocols are frequently lacking, in part to limited research conducted in academic settings that is directly applicable to school nursing practice. As a result, this gap in knowledge places the responsibility on the school nurse to independently develop care guidelines and provide ongoing education to personnel. Consequently, reliance on individual experience rather than formalized protocols leads to variability in care and increases the risk of student health complications and negative academic outcomes. Despite these challenges, established recommendations from medical and disease-specific organizations do exist, supporting the feasibility of developing standardized, evidence-based guidelines to promote consistency in care and improve student health outcomes. The purpose of this project was to create a high-quality, evidence-based clinical practice guideline to support school nurses in managing students with type 1 diabetes safely and effectively. The specific aims were to develop the standardized guideline informed by the latest evidence and national recommendations, and to evaluate its quality, rigor, and applicability using the Agree-To instrument in order to provide a practical resource that would be worthy for policy adoption. This project was guided by two theoretical frameworks. First, the Haynes and Jones translational model, a framework designed to bridge publication and research findings into clinical practice. The key elements acted as a roadmap for assessing research and literature findings, highlighting the core focus in developing the evidence-based practices and applying them to guideline development. And second, the National Association of School Nursing Practice, also known as the Framework for the 21st Century School Nursing Practice, which emphasizes care coordination, leadership, quality improvement, and evidence-based practice focused on student-centered care, safety, and academic readiness. These frameworks ensured that the developed guideline prioritized evidence-based practice and aligned with real-world responsibilities of school nurses. This project was a non-intervention project. However, the guideline was developed with a cooperating private school in a suburban area of St. Louis, Missouri. Approximately 88% of Missouri schools serve students diagnosed with type 1 diabetes. This school serves over 1,000 children and employs 2 part-time registered nurses, 50 teachers, teachers' assistants, curriculum coordinators, and administrative staff. All are Red Cross, CPR, and basic first aid trained. Select personnel are identified by school administration and trained as individuals who can administer care for students in the absence of the school nurse, and are delegated to provide care and dispense medications as prescribed by a physician. Their role as unlicensed assistive personnel is adjunctive to their primary position, as this designation is an additional responsibility rather than their full-time role. These individuals typically maintain their regular duties in other areas within the school, but are available to provide care when needed. It is important to emphasize that they are not substituting for the role of the school nurse, and due to their competing responsibilities, are unable to maintain the same level of continuous vigilance and clinical oversight that a school nurse can provide. The school currently services 3 young children living with type 1 diabetes. Although there were no patient participants or protected health information used in this project, 6 professionals from multidisciplinary areas, including a pediatrician, 2 master's prepared registered nurses, a doctoral prepared pediatric nurse practitioner, and 2 school personnel voluntarily participated in the evaluation of the guideline using the Appraisal of Guidelines for Research and Evaluation 2 instrument, the Agree 2. The Agree 2 instrument was chosen for this evaluation because it is a validated tool that systematically assesses clinical practice guidelines, rating 23 items across 6 domains: scope and purpose, stakeholder involvement, rigor and development, clarity of presentation, applicability, and editorial independence, and 2 overall items which invited assessors to provide qualitative comments to share additional insights. Review of current peer-reviewed research supported several key themes: the role of school nurses, implementation of diabetes medical management plans, blood glucose monitoring, infection control and documentation, medication safety administration, and the training for unlicensed assistive personnel. The following are the recommendations gathered from the themes within the literature review and disease authorities. These were developed into the guideline that was evaluated by assessors. Each statement was assessed per the Agree 2 instrument. In the area of roles of school nurses are expected to establish positive relationships with students and their families through consistent interaction, deliver comprehensive care to address the individual needs of students living with type 1 diabetes using an individualized diabetes management plan, provide routine education on type 1 diabetes to students, families, and school faculty, and tailor care to the students' and families' needs to eliminate barriers to successful management of type 1 diabetes in the school setting. Another component of the guideline includes diabetes medical management plans. A plan may be provided by the child's physician or developed collaboratively between the physician, parents, school nurse, and student when developmentally appropriate. School nurses are to ensure that the plan is current, on file with the school, and followed according to its instructions. In regards to blood glucose monitoring, infection control, and documentation, glucose levels should be monitored according to the frequency indicated in the student's individual diabetes management plan. Ensure that proper infection prevention is utilized when using glucose testing devices and other equipment. Follow standardized protocols for accurate documentation of blood glucose levels, carbohydrate counts, insulin dosing, medication administration, and communication with parents, healthcare providers, and school personnel will be demonstrated and maintained to minimize the risk of medication errors and ensure legal accountability, especially in the absence of the registered school nurse. And establish clear protocols and procedures for responding to hypoglycemia and hyperglycemia, including the administration of fast-acting glucose gel, carbohydrates, or insulin as determined by the student's individual diabetes management plan. In consideration of medication administration, all personnel should administer insulin via syringe, pen, or insulin pump according to the student's individualized diabetic management plan. All staff should be trained, and unlicensed assistive personnel should be able to identify emergencies as well as protocols for glucose management response. Train all unlicensed assistive personnel to properly administer insulin and glucagon to the student. Ensure that all licensed and unlicensed assistive personnel maintain accurate documentation of glucagon, carbohydrate, and insulin administration, including the time, dosage, route, location of injection if applicable, and any observed reactions. In the area of education and training of unlicensed assistive personnel, the school nurse should develop, or the school should have adopted, a comprehensive training program that includes understanding a student's individualized health plan and individualized diabetic management plan, procedures for blood glucose monitoring and insulin administration, recognition and response to hypo and hyperglycemia, emergency protocols including carbohydrate counts, students' glucagon and insulin administration, confidentiality, and documentation practices. Unlicensed assistive personnel's knowledge and skills should be assessed through written tests and hands-on demonstration at least annually. School nurses should provide oversight of educational material dispersed to unlicensed assistive personnel and other school faculty to ensure student safety. The Agree-To instrument does not provide standardized benchmark scores to determine guideline adoption, but instead allows users to determine thresholds aligned with identified project goals. For this project, a benchmark of equal or greater than 80% across all domains was used to represent acceptable methodological strength. Scores below the benchmark prompted targeted revisions. Domains that exceeded the benchmark on initial appraisal were determined adequate in quality and revisions were not made. In addition to domain scoring, appraisers were asked to provide an overall quality rating using a separate 7-point scale that indicated whether they would recommend the guideline for use. Their responses were recorded as nominal and ordinal data and were not incorporated into scaled domain calculations consistent with Agree-To guidance. The bar graph shown here compares the maximum points possible for each domain and the total points assessed by 6 appraisers. A scaled domain quality score was obtained by calculating the minimum and maximum possible scores using the instrument's instructions. Scaled domain quality scores identify strengths and weaknesses of a clinical practice guideline. However, the standard score does not correlate with the worthiness of a guideline being adopted, but can assist individuals in establishing criteria for adopting the guideline based on the domain score. As indicated earlier, a threshold of greater than or equal to 80% across all domains was used to indicate a strong guideline, whereas those lower than the threshold indicated areas of practice that needed to be addressed or had insufficient strength. Appraisers also rated the overall guideline quality using the 7-point Likert scale. Finally, the appraisers were asked to determine if they would recommend the guideline by providing the feedback yes, yes with modifications, or no. These responses were recorded as nominal data and not included in calculations of other data per the Agree instrument instructions. While the Agree instrument allowed opportunity for assessors to provide qualitative feedback regarding the guideline, All comments provided by assessors were in support of the implementation of such guideline and did not speak to the informational structure or provide suggestions for edits. Collectively, all domain scores met or exceeded the established benchmark, and all appraisers assigned the guideline the maximum possible quality rating and indicated support for its implementation in practice. These findings indicate that the clinical practice guideline demonstrates a high level of methodological rigor and overall quality. Based on these outcomes, it was concluded that revisions to the guideline were not indicated at this stage. As this project focused on a guideline development and appraisal rather than implementation, outcome data following adoption was not collected. Limited direct comparison with interventional studies were available. Nevertheless, the recommendations are grounded in current evidence and aligned with national standards, supporting their potential to improve consistency, safety, and quality in school-based diabetes management, effectively addressing the gap in school-based diabetes management and successful guideline development in the school setting where research is limited. Several strengths stood out in this project, including using the validated agreed-to instrument and having high inter-rater reliability by using more appraisers than minimum allowed. Limitations included that the appraisers did not provide significant qualitative data, the guideline is not exhaustive, implementation data is not available, and the guidelines were developed by a single author. Implications of practice include actionable recommendations for managing type 1 diabetes in the school setting, as well as supports the development of guidelines for other chronic conditions that affect students. Guidelines that are high quality, rigorous, and evidence-based ensure care is scientifically sound, promoting healthcare equity and reducing health disparities. The development of the guidelines provide potential for future research improving glycemic control, student safety when examining the implementation of the guideline. Standardizing clinical practice guidelines for type 1 diabetes in schools can improve consistency, safety, and quality of care for common chronic condition affecting children. These evidence-based guidelines help inform school health policies, strengthen nurse decision-making, and reduce reliance on individual experience. While widely used in healthcare, their adoption in school settings remains limited, highlighting an opportunity for improvement. Implementing such guidelines positions schools as leaders in student health and supports broader policy goals of equity and quality care. Additionally, this project provides a framework that can be applied to other chronic conditions in schools and serves as a model for advancing evidence-based policy during development in nursing practice. In conclusion, this project successfully developed a high-quality clinical practice guideline that fills an important gap in school nursing practice. Future work should focus on implementation and evaluation of outcomes. Key takeaways from this DNP project have included the significance of establishing evidence-based guidelines for chronic diseases in the school setting, especially for students with type 1 diabetes. Guidelines are not always available for instant implementation, but rather require translational research methods to create guidelines and protocols that improve safety and equity for all students. This DNP project strengthened my ability to translate evidence into practice, enhanced my leadership skills, and prepared me to contribute to quality improvement initiatives in healthcare. The following were references used in this project and could be reviewed for further consideration. I appreciate your attention and time. Thank you.